Hi, I'm Ziad Obermeyer at Berkeley, and I'm going to tell you about a couple of examples from my work that I think illustrate the central importance of labels in algorithms and how those can lead either to really bad things like algorithmic bias or good things like new scientific discoveries. So the two examples are going to be first an algorithm that by predicting a bad proxy ended up propagating massive amounts of racial bias in the healthcare system. And the second is some more recent work that I've done with some colleagues on an algorithm that actually, by listening to the patient and not to the doctor, ends up undoing a fair amount of unknown racial bias, previously unknown racial bias, in the way that we do medical classification, and could actually even lead to new scientific discoveries. And at the end, I'll actually try to tell you a little bit about an effort that I'm involved in that tries to scale up the second kind of work by creating open medical data sets for research. So the first example is drawn from some work that my colleagues and I published last year um, that starts with the observation that our healthcare system does a very poor job of dealing with complex patients. So these are patients with heart failure, with diabetes, on multiple medications that end up in the emergency department or in the hospital a lot with exacerbations of their chronic illnesses. And that's bad for them. And it's also bad for our healthcare system because all of those exacerbations end up driving up costs. So when you look at globally what the healthcare system has done to respond to that need, um, the universal thing you find almost everywhere is what's called high risk care management programs. And there's a lot of evidence that those programs are really helpful. So, what they are is essentially a team of very highly trained nurse practitioners who treat you when you're one of these patients like a VIP. So whenever you have a problem, they want you to call a dedicated line. If you need an appointment with your primary care doctor, they can get you on next day. It's really all hands on deck to help these patients with their health, to nip problems in the bud before they happen, to preserve those patients' health, but also to keep them out of the hospital. And so everyone wins. The patient wins, they're healthier, the health system wins, the care that we're delivering is less expensive. Now, of course, because that intervention itself is expensive, you can't do it for everyone. And so you need to target that program to make it worthwhile. And that's where algorithms come in. So in our healthcare system, the task of finding which patients to enroll in these programs is done by algorithms. And just to give you a sense of scale, we're going to be studying an algorithm that is by itself used to make decisions for about 70 million people every year. The family of algorithms, about 100 to 150 million people if you take industry estimates seriously. So the scale is enormous. And what these algorithms are trying to do is to find patients who are going to benefit most from these high risk care management programs. Now, as many of you know, estimating heterogeneous treatment effects is hard. And so, what most of these algorithms, in fact, all of them do, is substitute that with a far simpler task, which is to predict someone's future healthcare needs. So, concretely, what they do is they predict how much someone is going to cost the healthcare system next year. And then they're going to assume that the benefit of getting into one of these programs is proportional to that cost. So it's kind of a proportional cost reduction program. If I target people who are going to cost a lot of money next year, I'm going to find people that have problems today that I can nip in the bud and save their health and save the healthcare system money. So on its face, this actually sounds like a really great idea. It sounds like exactly the kind of thing that our healthcare system should be doing. Um, Despite that, we think a lot about algorithmic bias. And so in this setting, how would we know that that algorithm is biased? As you know, there are many, many different measures of bias that have been proposed, and not all of those can be simultaneously satisfied except under very specific conditions. So for any given application, what we're probably most interested in is the consequences of that bias. And so in our situation, here's how the algorithm is used. And that's going to tell us basically what bias would look like. The algorithm is used for screening. So every 4 or 5 months, the healthcare system that we worked with, just like many, many other healthcare systems that use this algorithm, they generate a score for all of their primary care patients. And then they use that score to screen. So if you fall into the top 2 or 3 percentile of that score, you're basically fast-tracked into the program unless there's a reason not to. If you're between the 55th and the 97th percentile, your case is presented to your primary care doctor, and your doctor just decides whether or not you belong in the program or not. So basically, two patients with the same score are treated the same way by the algorithm. So your screening priority is the same. And since that screening is being used to decide who should get extra help with their health, those patients should have the same health needs. So two patients with the same score, R sub I at a given time, should have the same future health needs that we're trying to prevent and deal with this program. That's going to be our working definition of what bias looks like in this setup. So what happens to patients at that same risk score? I'll show you a few graphs that look basically like this. So I just want to walk through it quickly. On the x-axis is that algorithm score. So we've just broken it into percentiles from low to high. And on the y-axis is one measure of future health needs. So this is number of chronic conditions that someone has that flares up in a given year. So if you have heart failure and you have to go to the ER or go see your doctor for that, that's a +1. And then we do that for all of your conditions. It's a fairly standard approach in this type of research. It's called a comorbidity score. And we've broken patients into Black patients in the purple line and white patients in the gold line. And as you can see, no matter where we are in that risk distribution, Black patients are on average less healthy. So they have more exacerbations or visits for those chronic conditions, no matter where we are. And we see that health difference not just in this measure of health, but in all sorts of measures of diagnoses, blood pressure severity, hemoglobin A1C for diabetes, end-stage renal disease. It really doesn't matter what you look at, we see this exact same pattern. And so what we tried to do is give you a sense of, how big this bias actually is. If we simulate what an unbiased algorithm would look like, and we can kind of get into details in the Q&A, an unbiased algorithm, if we look at who gets fast-tracked into the program, so to the right of that top line at the 97th percentile, that group at baseline is 18% Black. An unbiased algorithm would have made that group 46.5% Black. So this is not a small degree of bias that we're seeing here. Why did that bias happen? How did the bias get into the algorithm? Well, I actually already mentioned why. It's that the algorithm is using healthcare costs as a proxy for healthcare needs. So the label that the algorithm was predicting was how much are you going to cost the healthcare system next year? And as an interesting side note, if we look at for the stated task, for what we told the algorithm to do, how is it doing? We actually can see that the algorithm is doing A, pretty well, and B, it's doing well in an unbiased way. So here on the y-axis, instead of that future health need measure, I've put the total medical expenditures, the cost that it was supposed to be predicting. And you can see that the Black and the white patients at a given score actually cost about the same. The problem is that at a given level of health need, Black patients have, on average, lower costs. So on this graph on the right, instead of the algorithm on the x-axis, I've put our measure of health. So this is the number of chronic illness flare-ups that you have. And you can see that no matter where we are in that health distribution, white patients cost more. So that's about, it nets out to about $1,000 or $1,200 difference on average. And why is that? Well, that's of course because of what we all know about our healthcare system, which is that you don't always get healthcare when you need it, and that's especially true when you're Black and you don't have access to care because of the correlation between being Black and being poor, and also because doctors and the healthcare system in general just treats you differently when you are Black, and you end up with less care, and especially less care when you need it. So the mechanism of bias in this case was actually the choice of the task, the label that we set the algorithm up to predict. We said we wanted to identify patients whose health is going to deteriorate so that we can help them before it does deteriorate. And when us, humans are talking about these tasks, that's an easy thing for me to say. It's an easy thing for you to understand. But for an algorithm, that concept needs to be translated into a task in a data set where it predicts a variable. And so this is, I think, in the literature correctly being referred to as problem formulation. So how do we turn that abstract concept into a real task that an algorithm can do? And that choice of how we formulate the problem, the label that we set the algorithm up to predict, is so critical, but it's often an afterthought after we've cleaned the data and merged everything together and cleaned up the missing values. We often just say, okay, what do we predict? Let's just predict this thing because it's there and it's not missing. And I think that afterthought nature of that label choice is a really important mechanism of bias in a lot of different settings. Um, I'll also just note that it's a different mechanism of bias from what we read about often in the literature. It was not, in this case, introduced by using race as a predictor. In fact, the algorithm did not use race at all. The training data actually, the cost label was biased, but it wasn't about underrepresentation of the minority class, going outside the support of the data. And it wasn't also about deliberate trade-offs in design. Um, Let me say more about that now. It was the choice of label, and there were many reasonable alternative choices of label. So even if we were a profit maximizing user of this algorithm, it's not clear that you want to just predict total cost. So what we want to do is avoid costs by putting people into this program. So why not predict avoidable cost instead? Predicting total cost actually confuses two very different kinds of costs. You can imagine that someone who's diabetic and is taking their insulin costs money because insulin is expensive. But someone who doesn't take their insulin and goes on to have a toe amputation is expensive in a different way. And that distinction seems really important. You could also just skip predicting cost at all and go directly to predicting health. There are many measures of health. It just takes some effort to put them together in this data set. So the reason I feel pretty confident telling you that it was this label choice that was the source of the problem was because after we got some early results from this paper, we actually just contacted the company that makes the algorithm and told them what we found. And they were incredibly responsive. So they allocated some of their technical team to replicate our results on their training data set that they had originally developed the algorithm in. And then they were very motivated to work with us to understand that problem and try to fix it. And so we worked with them to, in the same data set, using the same prediction machinery, the same covariates, just predict a different label, which was a basket of health outcomes and cost outcomes. And by doing that, we got on one measure of bias an 84% reduction. So this is effectively at a given algorithm score, how many extra comorbidity flare-ups do Black patients have? And I think that really illustrates the importance of that label and the way we formulate the problem. So our second example is going to be, we're going to switch gears and actually talk about a completely different topic. So this isn't about costs or health services or health policy. This is actually about pain. It's a very clinical topic and a very important one given all of the attention to opiates today, which has its roots in pain. And one of the observations from this very large literature on pain is that there are very large gradients in pain by disadvantage. So non-white patients have more pain, poorer patients have more pain, and less educated patients also have more pain. Now, there's an obvious explanation for this, which is that all of these disadvantaged patients probably have higher prevalence of things that hurt. Like if we're talking about the knee, which is a very common source of pain, osteoarthritis. So we do actually see these same kinds of gradients where poorer people have more arthritis, less educated people also have more arthritis. But that doesn't seem to be the whole story. So we can actually just adjust for those differences in the kinds of things that cause pain. So we can kind of control for it or hold the severity constant. And so, if we're again talking with our example of knee arthritis, we take two patients who basically have the same degree of severity on their x-ray. So we look at it, we see the same degree of arthritis, and we ask who has more pain. And the finding that is really striking is that disadvantaged patients actually have more pain even when their knee x-rays look the same. So even after we adjust for that difference in severity, they have more pain. If you had to kind of group the explanations from the literature into a category, the dominant theme that comes out of that literature is the observation that, well, if the difference in pain doesn't have its roots in something in their knee, if we can't see a difference in their knees, then maybe it's in their heads. And I don't mean this in any pejorative sense. There's a vast amount of research on the role of stress in aggravating the sensation of pain. There's also a lot of good literature on how psychosomatic complaints can manifest differently along these gradients of income and education. There are differences in coping strategies, both internal and things that are prescribed by doctors to different patients. And so all of these explanations basically say, well, we don't see a difference in the knee, so it has to be somewhere else in society, in psychiatric illnesses and different levels of stress. And so those are the things that we need to be targeting with our interventions. Now, there's a different explanation that I want to propose to you. Let's start with that concrete example. So imagine an underserved patient, a non-white patient, a less educated, a lower income patient coming into the doctor with lots of pain in her knee. The x-ray doesn't look that bad. It doesn't look as severe as you'd expect given the level of pain. But what do we mean exactly by severe? And how do we define that? What's our technology for assessing severity? Well, this is the technology. It's someone looking at an x-ray and judging it according to some objective criteria of arthritis. So that does raise the question of, what if there is an objective problem? There is a real difference in that x-ray, but the doctors don't recognize it. So picture that patient, lots of pain, normal looking x-ray. If the doctor is missing what's causing her pain in that knee x-ray, it could actually be in the knee after all. And I think anyone who has kind of looked into how we come up with these classification systems in medicine knows that this is very possible. So in this case, where does our grading system for arthritis come from? Well, it comes from doctors Kellgren and Lawrence, who in 1957 published a study of knee pain in coal miners in Lancashire, England, and developed the classification system that still bears their name. One interesting factoid to give you a sense of where the bias might come in is that in that original set of studies, there is in fact no mention of subject's race, because when something is the same, you don't really need to mention it. But suffice to say that there were no diverse patient populations or attention to capturing a diverse patient populations in these original studies. So all of that brings up the question of, what is the right label then? So if we want to make headway in understanding why some patients have more pain and some patients don't, we can't just use what the radiologist is saying. We can't train the algorithm to replicate the radiologist. So we don't just want to label this image with the Kellgren-Lawrence grade or some other derived system. But there is a different way to do it, which is that instead of learning from the doctor, the algorithm could learn from the patient. And we could train an algorithm to actually go from the x-ray image, not to the radiologist's interpretation, but to the patient's experience. Now, I'll note one thing that will be obvious to many of you, which is that finding the data to do this was not straightforward. It's very easy to find data sets of just the x-ray with what the radiologist said about the x-ray. That's sitting on every hospital's imaging system. It's a lot harder to find x-rays with the patient's pain experience linked to those images. So how did we get this? Well, I moved to Berkeley from Boston 2 years ago, and I was starting to try to figure out how to do this project. And we requested this imaging data set from NIH because they were supposed to have made it public. And they were very kind, and they referred me to one of my colleagues at the Brigham where I was working, because the data set wasn't ready yet. So they hadn't actually managed to get it up onto their site yet, and they were cleaning a lot of data. And so a couple of days before I left Boston, I met my colleague at the hospital, and he said, if you can get me a hard drive tomorrow with however many terabytes of space this data set needed, I can leave my thing on overnight and download all the images onto that. And my flight was that Monday. So luckily, I managed to get this all done in time and get the data downloaded. But that's how we got the data. Basically, it fell off a truck with all of the relevant NIH approvals and ethical oversight in place, of course. Once we had that data, though, it became a very, very straightforward machine learning problem. We have the image, we train the network, and we predict not the radiologist's judgment, but the amount of knee pain that that patient had. And then we can ask the question, our test is, does the algorithm or the doctor explain that extra pain among the disadvantaged better? So I'll start by telling you that the black-white gap in pain on a scale of 1 to 100, where severe pain is 86 or less. 100 is normal function, and pain increases as the score goes down, somewhat counterintuitively. When you just look at the average score difference between blacks and whites, it's just over 10 points. So that's without controlling for severity. When we control for uh, the, um, the differences in objective severity as measured by the radiologist, that pain gap goes down a little bit. So it goes down by 9%. When we control for the algorithmic severity measure, so this is the predicted pain score based on the image alone, we actually have dramatic reductions in that gap. So this is explaining about 5 times more of the black-white difference than the standard radiological measure of severity. And we see similar results for income and education. I'll note one interesting set of facts about the model is that the diversity, socioeconomic and ethnic diversity of the training set turns out to be very important here. So if we retrain the algorithm only on white patients, that really hurts the model's performance and it hurts its ability to explain this pain gap. And we think that this is finding real signal. We can do this with other types of clinical scores besides KLG. We can run it on the MRI-derived scores as well. We can show that it's not just a reweighting of what the radiologist said about the image. And we can also show that this is robust to training on some study sites and predicting in others. So this isn't just learning something different about the places where people get x-rays. Does this matter? Well, there's actually a really important concrete decision here that comes out of measuring severity accurately. And that's that we actually have treatments for knee arthritis. Knee replacement surgery really changes people's lives by getting people who have been bedridden because of pain out and in some cases walking and skiing again. Now, that surgery only works if the problem is in your knee. And so, very naturally, we only consider people eligible for surgery when they have pain and their arthritis looks bad on the image. But again, what do we mean by bad? So, if we do a simulation where instead of allocating those surgeries according to the x ray severity measures of the radiologist, we allocate based on what the algorithm says, we would actually more than double black eligibility for surgery. So this is a potentially really important mechanism by which Black patients end up getting offered knee surgeries less often than white patients, not through any explicit bias, but by virtue of the way we've actually constructed our scores for radiographic severity. So I'll just try to compare and contrast these two cases. I think all of us know that we live in a very biased society that produces very biased data. And I think that there's a sense in which people believe on some level a very pessimistic story about algorithms, that because of that, we just can't get around the fact that algorithms are going to be biased. But I think one of the things that I've learned from starting to work in this area is that that bias is not inevitable. Certainly, as in our first example, the algorithm can learn from biased labels. It can propagate all of the structural factors that we hate about our healthcare system and our society and lead to the rich getting richer, people who have used more healthcare in the past getting more health resources in the future. But as the second example shows, they can also learn to predict the right quantities and undo some of the previously unappreciated racism that was built into the DNA of our medical classification systems. And so that I think is it's a much more optimistic story than I think I expected to find going into this work. And really what it means is that which of those two happens, whether it's um, the regressive algorithm that punishes people who generate biased data, or if it undoes that bias, it's really up to us and the technical choices that we make when we train those algorithms. Um, as the second example shows, and as I alluded to, doing that work well depends on access to high quality data with interesting outcomes that you can use to label images and other examples. But these medical data sets are frustratingly inaccessible much of the time. So the last thing I want to tell you guys about is a project that I'm involved in that is trying to solve that problem around inaccessibility of medical data. So what some colleagues and I are building is effectively an open data platform for research in this area that's bridging um, imaging, computation, medicine, clinical decision making, where we try to bring together health organizations with a commitment to doing research in this area with researchers like you guys who want to work with these data. And so all of the work that we're doing is building up these interesting high dimensional data sets, a little bit like those the data set that I mentioned of knees linked not just to what the radiologist said, but also linked to interesting outcomes. So you can think about this a little bit like an image net for medicine, but instead of being labeled with what the radiologist said about the image, we're labeling these things by doing a lot of curation and linkage and merging in electronic health records and cleaning those up so that you can get real outcomes that open a window into these kinds of new questions, not just into health policy, but issues like pain, cancer staging, sudden cardiac death, with x-rays and electrocardiograms and ultrasounds all built in. Concretely, we are building a cloud infrastructure where you'll find many of the tools that you're used to using, Jupyter notebooks, Docker containers, and where you'll be able to, with one DUA, get access to a lot of these really fascinating data sets, get full access to a subset so you can look and see how the models are running with respect to real data, and then be able to send the models to train and run and produce results on the full data sets of tens of thousands or hundreds of thousands of examples. The way we do this is first, I should acknowledge a lot of very generous support from Berkeley, from University of Chicago, and most of all from our funders. Our anchor funder is Schmidt Futures. We've also been lucky enough to be funded by the Moore Foundation. And all of that has allowed us to build really strong partnerships with health systems that are committed to this vision of the future of medicine and whose real goal is actually collaborating with people exactly like you. So the last thing I'll mention is that if you want to learn more, or if you want to be one of our beta testers, please drop us an email and we'll look forward to hearing from you. Thank you so much.